Welcome, and thank you for joining the American Heart Association for this educational webinar for healthcare professionals entitled Supraventricular Tachycardia, Mechanisms and Clinical Presentations. This is the first webinar of a three-part series of our Supraventricular Tachycardia initiative, and it's supported by Milestone Pharmaceuticals. But please note, it's important that all of the program material was developed independently from the sponsor. I'm Dr. Andrea Russo, and I will be your moderator today. I'm professor of medicine at Cooper Medical School of Rowan University and director of cardiac electrophysiology. Joining me as my co-moderator is Dr. Brian Olshansky, and I'll have him introduce himself, please.
Well, thanks, Andrea. I'm looking forward to a very exciting session today. I'm a professor emeritus at the University of Iowa, Hospitals and Clinics, and an adjunct professor at Des Moines University. I'm in clinical practice as an electrophysiologist at the Iowa City VA. I work in Mercy One in Waterloo and also in Illinois. It's a pleasure to be here.
Great. Thank you. Thank you so much, Brian. And for this discussion, we're also joined by three other experts in this area, Drs. Melanie Mayton, Dr. John Piccini, and Dr. Emily Zeitler. And I'll ask you to please just introduce yourself in that order.
Hi, my name is Dr. Melanie Mayton. I am a clinical electrophysiologist at Brigham and Women's Hospital and also a clinical investigator. While I love all things EP, my area of research interest lies in device and lead management.
And my name's John Piccini. I'm a professor of medicine at Duke University and director of the cardiac electrophysiology session. And I'm very much looking forward to speaking with everyone today about supraventricular tachycardia.
Hi, I'm Emily Zeitler. I'm assistant professor of medicine at Dartmouth, Hitchcock Medical Center at the Dartmouth and the Geisel School of Medicine at Dartmouth. Really excited to be here. What an amazing lineup. I'm thrilled to be part of it and can't wait for the discussion. Thanks for having me.
Great. Thank you all for joining, and I'm really looking forward to the presentations and the discussions. Please note that the views and our opinions are our own and reflect the synthesis of science and evidence-based medicine, and this content is not considered the official policy of the American Heart Association. This slide shows the disclosures of the moderators and panelists. So after the presentation, we have a Q&A session where you can ask questions. Please take this moment to open up the Q&A feature in the toolbar of the Zoom screen. And throughout the program, just enter your questions in the Q&A feature, and we will answer them after the presentations as all time permits. So here are our learning objectives. The first is to recognize the different types of SVT. The second is to understand non-invasive and invasive methods for diagnosing SVT. So now I'd like to go ahead and turn this over to Dr. Emily Zeitler.
Thanks, Andrea. I think I'll jump right in. I've got a lot to cover. We're going to discuss mechanisms of SVT as a way to set the stage for my colleagues, Dr. Mayton and Dr. Piccini, to discuss diagnosis and treatment. So let's just go ahead and get started. Here is the list of SVTs that we'll talk about. Each of these will be a pretty brief discussion because we don't have a ton of time. And to set the stage, I just want to be clear about what we mean by SVT. We define this as a rhythm of at least 100 beats a minute that's originating from the His bundle or above. So it's really an umbrella term, and you may think, well, where's atrial fibrillation? And you would be right to think that. It's really a convention that atrial fibrillation is not included in this discussion, so we won't be talking about it specifically. It really deserves its own webinar. But we will talk about it very briefly as part of our discussion of special situations with accessory pathways. We'll start at the top, the very top, sinus tachycardia, which is a tachycardia that's a special kind of atrial tachycardia, which I'll discuss next. The sinus tachycardia originates from the sinus node, and the sinus node is beholden to all kinds of inputs Some of these are physiologic, like pain, or medical, like anemia, or even the effect of substances like caffeine, which can all impact the sinus node activation rate through a variety of mechanisms, which are shown schematically in the bottom right. On the top right, you can see a graph of heart rate with the effect of sinus tachycardia over time. And you'll note that there's a gradual decline and a gradual incline in the heart rate over time. And this is pretty typical of sinus tachycardia. It has this warm up and cool down characteristic. When we cannot identify a trigger or a cause for sinus tachycardia, we may label it inappropriate sinus tachycardia. And this is when we have persistent sinus tachycardia of at least 100 beats a minute without a cause that's identifiable and with accompanying symptoms. And this can be a really difficult problem to treat because we want to treat the inappropriate sinus tachycardia without affecting the normal physiologic response to some of these triggers. Atrial tachycardia, I promised to tell you about it because sinus tachycardia is a special type. I'm showing you in the top right a video of an atrial tachycardia that is starting at an area near the sinus node in an area of the crista terminalis, which is a common area for initiation of atrial tachycardia, but truly this can come from anywhere in the atrium, from a focal source. And I'm showing in the bottom right a schematic of where atrial tachycardias tend to come from, and you'll notice a big clump of black dots around this area extending from the sinus node inferiorly towards the IVC. And this is the crista terminalis, which has a lot of the same properties of the sinus node. So what that means is an atrial tachycardia can have a lot of the same characteristics of sinus tachycardia and can be hard to distinguish, in fact, especially if it's coming from an area near the sinus node where the P wave may look really similar. Also important to note about atrial tachycardia is that it really doesn't care what's happening below. It doesn't care what's happening at the AV node or in the ventricle. So what that means is that if we do things to slow down conduction in the AV node with adenosine, for example, or vagal maneuvers, both of which you'll hear more about from Dr. Mayton, it may have no impact on atrial tachycardia. In fact, it's less likely to have an impact on this rhythm than some of the others that we will discuss, because atrial tachycardia simply doesn't care what's happening below. And I'll give you an illustration of that here on this slide. In the top strip, electrogram strip, you see the first blue arrow pointing at a weird looking P wave, an upside down P wave, showing that atrial activation is coming from somewhere other than the sinus node. This is very atypical. And then further in the strip, the second blue arrow is pointing at a different form of a P wave that's upright, looks more normal. So we're seeing a transition from an atrial tachycardia, an ectopic atrial tachycardia, transitioning to sinus tachycardia. So this is a clue. This may be an atrial tachycardia. In the bottom strip, we see two blue arrows pointing at two separate P waves that are with no QRS complex in between. This gets to the point of the atrial tachycardia not caring at all what's happening below. Whether it conducts to the AV node of the ventricle is no concern of the AT. So if you see this pattern with two P waves without an intervening QRS, you should be suspicious that maybe you're dealing with an atrial tachycardia. Moving on to atrial flutter. Atrial flutter is a macro-reentrant rhythm, and one of the most common forms is so common, in fact, that we sometimes call it typical atrial flutter. I'm showing a video of the right atrium in typical atrial flutter. You can see the electricity is propagating in a counterclockwise fashion around the tricuspid valve. And that's how atrial flutter operates. It is a macro-reentrant rhythm going around some barrier, but that barrier doesn't have to be the tricuspid valve. It often is, but it could be the mitral valve, or it could be any area that presents an electrical barrier, like scar tissue from a prior ablation or surgery on the heart, or even extensive fibrosis can work as a barrier to allow flutter to go around that barrier. It's important to note that atrial flutter does not coexist simultaneously with atrial fibrillation, but patients often have both, and they can transition back and forth between atrial flutter and atrial fibrillation. So they're closely related, but don't coexist. Here's an example of typical atrial flutter on a 12-lead ECG. I'd like to invite you to imagine this ECG without any QRS complexes. And if you did that, what you would see is continuous atrial activity with a sawtooth pattern especially if you look in the inferior leads, 2, 3, and F, for example, you see this continuous activity with downward deflection continuously throughout the strip. This is showing you that the atrium is never going to sleep. It's never stopping. It's continuous electrical activation. Moving on to AVNRT, atrioventricular nodal reentrant tachycardia. This is the most common form of SVT, but perhaps the most complicated. Now, very much like we just discussed with atrial flutter, it does require two limbs in order to propagate this reentry. But the reentry is all within the AV node as opposed to a big reentry circuit like around the right atrium. Here what we have is the reentry circuit that enters the AV node, encounters one limb being refractory, so it propagates down the other limb of the AV node. When it gets to the bottom, it encounters a recovered limb and goes retrograde up the recovered limb, and around it goes. As it does so, it may activate the atrium and the ventricle, but it may not, because this rhythm is all contained within the AV node. It can be initiated with an extra beat from the top of the heart or the bottom of the heart. When it initiates from the top of the heart, an extra beat travels through the atrium to the AV node. It may encounter a refractory limb in the fast pathway, so it conducts slowly down the slow pathway. On its way, it activates the ventricle and then turns around and goes back up the fast pathway, and you're off to the races. Around and around it goes. In this form of AVNRT, the atrium gets activated retrograde through the fast pathway, which means that it may get activated right on top of the ventricle. So it can be very difficult to see atrial activation on the surface EKG in this scenario. And I'll show you an example of that. Because AVNRT exists entirely within the AV node, maneuvers and medicines that affect the AV node can slow or terminate conduction, like you might see with adenosine. Again, we'll hear more about this from Dr. Maton and Dr. Piccini. Here's an example of a surface ECG of typical AVNRT. Again, this means conduction down the slow pathway of the AV node and then back up the fast pathway. And I'd like you to focus on the maroon arrow pointing at the very end of the QRS complex in V1. Here we see just a little ditzel, and you might wonder if that reflects atrial activation right on top of ventricular activation. And you'd be right in this case. Because in sinus rhythm, this is the same patient in sinus rhythm, the maroon arrow is pointing at the same portion of the QRS complex in V1, but we don't see that little ditzel. And I'll show you a zoomed up version of it. You can see the difference in tachycardia on the left and in sinus rhythm are on the right. And this is a clue. If you're lucky enough to have an EKG in normal rhythm, you may be able to look at V1 and see a little ditzel suspicious for atrial activation and make the presumptive diagnosis of typical AVNRT. In contrast, here's an example of atypical AVNRT. This means in most cases that activation is down the slow pathway, down the fast pathway, and then retrograde up the slow pathway. So what that means is the atrium is activated later than the ventricle, as opposed to right at the same time. And so that on a surface ECG, what that looks like is retrograde atrial activation is pushed out away from the QRS complex. If you look at lead 2 in this ECG, the maroon arrow is pointing at an upside down P wave. This is retrograde atrial activation via the slow pathway of the AV node. Atrioventricular reentrant tachycardia, or AVRT, is also a macro-reentrant tachycardia, meaning big circuit. And this one is special because it actually requires the involvement of the ventricle. It's the only SVT that actually does require the ventricle. In this case, in addition to the ventricle, it requires two pathways between the atrium and the ventricle. And in most cases, that's the AV node and an accessory pathway. If an accessory pathway exists and it lends itself to SVT, then you've got Wolff-Parkinson-White syndrome. But SVT in this case can happen in really two main ways. You can go forwards or antegrade down the accessory pathway. And in that case, you would see a big wide QRS that's pre-excited, and then through the ventricle and back up the AV node. But it can go the other way around too. You can get forwards conduction down the AV node and then backwards up the accessory pathway. And we name these rhythms based on the direction of conduction across the accessory pathway. Forwards, we call it anadromic, and backwards, we call it orthodromic. So in this case, if you have orthodromic atrioventricular reentrant tachycardia, then you would have a narrow QRS. And I'll show you an example of that. Here's an example of orthodromic AVRT. Again, this means forward conduction down the AV node, through the ventricles, and then backwards up the accessory pathway. So you have a narrow QRS because you have AV nodal conduction, and then retrograde atrial activation is delayed because it requires conduction all the way through the ventricle before it goes back up the accessory pathway. So the maroon arrows here are pointing at the retrograde atrial activation. And you might look at this and think, well, how can I tell the difference between this and atypical AVNRT, where the retrograde atrial activation was also extended outside of the QRS complex? And you would be right to think that it can be very hard to distinguish these two things, and it's easy to mix them up on a surface EKG. I told you I wasn't going to talk about atrial fibrillation, but I'm okay being called a liar because we have to mention it when we're talking about accessory pathways. The problem is in atrial fibrillation without an accessory pathway, the AV node gets bombarded. And because the AV node has decremental properties, it actually protects the ventricle. It doesn't let all of that chaotic electricity travel through the AV node. It really does protect the ventricle by only letting through some of the electrical activation. But when an accessory pathway is present, the accessory pathway may not be so kind to the ventricle and may allow much more rapid electrical activation of the ventricle, which increases the risk of AFib degenerating into ventricular fibrillation. This is more likely to occur if the AV node is blocked. And the AV node may be blocked by routine interventions that are performed for rapidly conducted AFib, like the administration of beta blockers or calcium channel blockers. It's important to notice when you've got a pre-excited atrial fibrillation because those interventions can increase the risk of unopposed conduction across the accessory pathway, leading to complications like ventricular fibrillation. It's much safer to treat this with a drug to block the accessory pathway, like procainamide, or to deliver electrical cardioversion to restore sinus rhythm. Finally, I'd like to mention the permanent form of junctional reciprocating tachycardia, or PJRT. This is an uncommon form of orthodromic reciprocating tachycardia. To remind you, that means conduction down the AV node and back up an accessory pathway. In this case, it's across an accessory pathway in the AV group. And this EKG I'm showing you, the first maroon arrow is pointing at the first retrograde activation across its accessory pathway. The first two beats are sinus, and then the third beat is retrogradely activating across the accessory pathway. This is important because it can be incessant, and it typically occurs in children and adolescents. And if it's incessant, it can lead to tachycardia-mediated cardiomyopathy. So it's critically important to recognize and to treat in order to avoid the development of cardiomyopathy. That concludes my whirlwind tour of the mechanisms of SVT, and I'm delighted to hand it over to my colleague, Dr. Mayton, to walk us through non-invasive methods for diagnostics. Thank you.
Thank you, Dr. Zeitler, for that very comprehensive overview of SVT mechanisms. We are going to continue the discussion by moving on to additional diagnostic methods for diagnosing SVT, including non-invasive maneuvers such as vagal maneuvers, medications that can be used to block the AV node to unmask or possibly even terminate the arrhythmia, the role of epicardial ECG leads in the postoperative patient, ambulatory cardiac monitoring, including wearables, and non-invasive testing for risk stratification of accessory pathways. And finally, a brief introduction to electrophysiologic testing, which will be covered more by Dr. Piccini. So, as you all are aware, the autonomic nervous system is composed of both sympathetic and parasympathetic divisions. In the heart, parasympathetic or vagal stimulation causes the local release of acetylcholine, which results in slowing of both sinus node impulse formation and slowed conduction, as well as lengthening of the effective refractory period in the atrioventricular node. Vagal maneuvers can be used to increase the vagal parasympathetic tone in an attempt to both diagnose and potentially treat various arrhythmias. A number of common maneuvers are employed to reach this goal, and these include carotid sinus massage, Valsalva maneuver, the modified Valsalva maneuver, and the diving reflex. The reported success rates range quite widely from 5 to 50%, with the modified Valsalva maneuver having the highest likelihood of SVT termination. So as we've heard mentioned a couple of times, adenosine and vagal maneuvers are very useful interventions in the management of SVT and are considered first-line therapy. These interventions slow the heart rate to help assist in the diagnosis of the SVT and potentially even terminate the tachycardia. The typical starting dose is 6 milligrams IV push of adenosine, followed by a large 20 cc saline bolus, with incremental increases in doses of adenosine if the desired effects are not achieved. Most, if not all, patients develop symptoms from activation of the acetylcholine receptors in the vasculature and vasodilation, which can include dyspnea, chest pain, flushing, lightheadedness, and a sense of impending doom. Adenosine is contraindicated in AV block in those with reactive airway disease and pre-excited atrial fibrillation. And the dose needs to be reduced for central venous access and in cardiac transplant recipients. AV nodal agents can be considered as a second-line agent if the above is not effective or not feasible. The 2015 AHA-ACC HRS guidelines on the management of SVT in a hemodynamically stable patient with a regular narrow QRS tachycardia recommend the use of vagal maneuvers and/or adenosine as the management, as previously stated. If with these interventions you see a sudden termination of the arrhythmia, the most likely diagnoses are reentrant tachycardia, such as AVNRT, AVRT, or SNRT. But as Dr. Zeitler mentioned, there is a small percentage of atrial tachycardias that are also adenosine sensitive and can terminate with adenosine administration. If we see persisting tachycardia, but with atrioventricular block following the administration of adenosine, the diagnoses you should be thinking about are either atrial flutter or atrial tachycardia. If there's a gradual slowing of the tachycardia followed by reacceleration after adenosine administration, we should be thinking of entities like sinus tachycardia, atrial tachycardia, or junctional tachycardia. If there's no change in the heart rate following adenosine administration, then either the dose was inadequate or it was incorrectly administered, or perhaps the tachycardia is ventricular in origin. This EKG is an example of how adenosine can help unmask an arrhythmia. On the left-hand side of the tracing, the flutter waves may not be obvious to all, but following administration of adenosine, we clearly see some unmasking of these flutter waves, enabling us to make the correct diagnosis. Epicardial leads are another tool that can be very helpful in the diagnosis of SVT. They are often routinely placed following cardiac surgery, and atrial pacemaker wires can be used to create an atrial electrogram with augmented P waves. These diagnostic atrial electrograms are very useful when you can't clearly identify the P wave on the surface electrocardiogram, and they can also be therapeutic when used to overdrive pace arrhythmias and attempt to terminate reentrant SVTs. In this EKG on top, we see that we have a narrow complex regular tachycardia. And while we see some evidence of atrial activity, we may not be exactly sure what the rhythm is. In the bottom panel, you can see that the atrial electrograms clearly show that there is a atrial arrhythmia with 2-to-1 conduction to the ventricle, and help us with the diagnosis of atrial flutter. In this example, we can see the atrial electrogram showing us both the onset and offset of a junctional tachycardia and aiding in a diagnosis when we really might not be able to otherwise see atrial activation on the surface ECG. Ambulatory cardiac monitoring is a tool that we frequently use to help us in the diagnosis of SVT. There's a wide range of options for cardiac monitoring, from the Holter monitor, which I would say is employed less often nowadays, but is useful in the individual who is having frequent, that is daily, symptoms in an attempt to capture their arrhythmia and aid in the diagnosis, to MCTs, which can help us in the patients who have less frequent symptoms and can provide very detailed reporting and often even real-time data transferring and monitoring. Wearables are an evolving technology that is really sort of exploding and overtaking the market. They use a technology called photoplethysmography, which measures the change in volume of the heart by measuring light transmission or reflection using a sensor on the skin in close proximity to an artery. And so during systole, the rise in pressure forces the pulse into the blood, a pulse of blood into the vessel. The device is shining light onto the skin to detect that by measuring the difference in the quantity of light reflected back to the sensor. There are numerous available wearables on the market today, however, only 2 at present with FDA approval for the detection of atrial fibrillation. The limitation to these devices, while similar to ambulatory cardiac monitoring, is that obviously they can only detect arrhythmias when they are used or worn, and often the monitoring is not always continuous. So a few words about non-invasive risk stratification. It is important to consider the evaluation of patients with pre-excitation to determine the risk of rapid conduction over their accessory pathway and their risk of life-threatening ventricular arrhythmias. And risk stratification is generally performed by evaluating the antegrade or forward conduction over the accessory pathway by either non-invasive or invasive testing. Non-invasive testing is generally considered safe and should be considered in asymptomatic patients. It can include and should include standard 12-lead ECG, ambulatory monitoring, and exercise stress testing. And what we're looking for is loss of pre-excitation to suggest that that antegrade or forward conduction over the accessory pathway is poor and that that individual is at low risk for sudden death. The abrupt loss of antegrade accessory pathway conduction or pre-excitation with exercise is a better marker for low risk than intermittent loss of pre-excitation on ambulatory monitoring or surface ECG. The caveat being that non-invasive testing has a robust ability, 90% positive predictive value, to identify pathways that have life-threatening properties, but has a much lower negative predictive value. There are also other risk factors that are associated with malignant arrhythmias in WPW, including gender, the presence of multiple accessory pathways, and also the electrophysiologic properties of those pathways. And so in some patients, invasive electrophysiologic testing can be considered to aid in the diagnosis as well as risk stratification of the accessory pathway, specifically looking at features like how fast the pathway can conduct when the patient has induced atrial fibrillation, as well as how fast the pathway recovers. And those are things that I think Dr. Piccini might touch on a little bit more. And then there's obviously the treatment of catheter ablation for symptomatic patients, either as first-line therapy or for those who have failed medical therapy, as well as in asymptomatic patients who have high-risk features of their accessory pathway and or have a type of employment that precludes the continued employment should they have an accessory pathway. And I think this represents a nice segue into Dr. Piccini's talk about the invasive methods for diagnosing supraventricular tachycardia.
Thank you, Dr. Mayton. It's my pleasure to speak with everyone on invasive methods for the diagnosis of supraventricular tachycardia. And as often the case with these talks, some of the information is repetitive, and I think that's good because it's going to allow us to reinforce some very important concepts that merit repetition. Now, I know that most people participating in this session today are not cardiac electrophysiologists. And so just to review at the very beginning, when we think of invasive diagnostic methods in electrophysiology, typically what we're talking about is the electrophysiology study. There are other invasive techniques for diagnosis, but this is by and large the bulk of what we're talking about. And most patients are familiar with going to the quote lab for cardiac catheterization, but this study is very different. On the left, you can see that its study requires or involves placement of catheters at several specific anatomic locations in the heart. And each of these locations reveals different information about cardiac activation and conduction. Each of these catheters then records a signal that allows us to assess not only the health of normal heart rhythm and cardiac conduction and structures such as the AV node and the His bundle, but it also allows us to diagnose abnormal cardiac activation, including abnormal cardiac rhythms, one of which being supraventricular tachycardia. Just to be clear, the panel on the right here are recordings from an electrophysiology study that's being done in normal sinus rhythm at the time of this screenshot here. There are 4 leads from the EKG shown at the top. There are 2 electrograms or electrical recordings from the atrial tissue, 2 from the vicinity of the His bundle, and you can see on His distal, you can see the atrial electrogram, the His bundle electrogram, and the right ventricular electrogram. Then there are 4 recordings from the coronary sinus that sits between the atrium and ventricle in the coronary sinus with depiction of near field atrial electrograms. And then finally, we see electrograms from the right ventricular catheter. Again, the details are not so important, but understanding the general type of information that electrophysiologists gather during these studies is what's important. Well, what are the basic principles of these so-called EP studies? So, as I mentioned, it allows us to provide a precise diagnosis of the underlying arrhythmia and its mechanism and localization of the site of origin, which is very important not only for identifying what the nature of the patient's problem is, but also potentially how we can fix it with catheter ablation. Once a patient goes into SVT during the study, either because we provoke it with rapid pacing or we provide infusion of a medication and induces the abnormal rhythm, much like sonar sends a sound wave and makes conclusions about objects based on the return of those sound waves, we perform pacing maneuvers where we introduce wavefronts of activation into an abnormal rhythm. And then based upon the pattern and timing of the return of those electrical waves, we can determine what type of arrhythmia someone has and what the mechanism is. Of course, once we do that, then we can potentially provide a recipe or a method for eliminating the abnormal rhythm. And in many cases, not all, but in many cases, this can be curative. As with all cardiovascular procedures, complications can occur. They are relatively rare, but they can be in some situations life-threatening or life-altering, and we'll talk about them a bit more. Well, when is an EP study indicated? An EP study in cardiology can be indicated for a large variety of reasons. Patients with regular SVT frequently have indications for an EP study. And if there is pre-excitation suggestive of the presence of an accessory pathway, Dr. Maton has already reviewed some of the indications for an EP study. But even without pre-excitation, if a patient has symptomatic supraventricular tachycardia or supraventricular tachycardia that's clinically relevant and of unclear cause or origin, EP studies have a class 1 indication in those situations. We're talking today about regular supraventricular tachycardias. So absent atrial fibrillation and atrial flutter, supraventricular tachycardias largely have three causes, as you've already heard. The most common of these in the population is AV node reentry, followed by atrial tachycardia, and then accessory pathway-mediated tachycardias, which are relatively infrequent when compared to these other causes of arrhythmia. In patients who have AV node reentry, the SVT guidelines, which I highly recommend, is a very valuable read. They give a lot of background and can go into far greater detail than we can in a 1-hour webinar. But if a patient has AV node reentry, catheter ablation of AV node reentry is a class 1 indication for persons with symptomatic arrhythmia. And an EP study, of course, is the first step in that process. They can be performed in the same procedure, but the EP study is how we begin to make that diagnosis, provided or on top of the clues we receive from electrocardiograms and responses to adenosine, has been previously highlighted. Shown here is a schematic, an anatomic image from the septum. And our AV node has inputs, including fast inputs and slow inputs or pathways. And you can get reentry where an abnormal impulse circles through these pathways, as Dr. Zeitler has indicated. And catheter ablation or destruction of that slow pathway cures AV node reentry with rates exceeding 95%. Shown here is a video, if I can get it to play, of AV node reentry. It doesn't want to look like it wants to play. But again, this is a, there we go. This is a reentrant rhythm where the electrical impulses travels through those inputs into the AV node. And again, a local application of radiofrequency energy or cryo-energy can cure this arrhythmia. What about atrial tachycardia? We've heard about atrial tachycardia. If a patient prefers catheter ablation for symptomatic atrial tachycardia, catheter ablation is a class 1 indication. Of course, often we will treat atrial tachycardias with medical therapy, but catheter ablation is a class 1 indication. And an EP study can allow us to ascertain where that focal source or micro-reentrant source of atrial tachycardia is coming from. Again, these are focal arrhythmias that can have distinct mechanisms, including enhanced automaticity, triggered activity from after depolarizations, or micro-reentry, where the impulse travels over a circumscribed path, but that path is over a very small area of the myocardium. And occasionally we can run into adenosine-sensitive atrial tachycardias. So not all arrhythmias that terminate with adenosine are dependent on the AV node. And again, just to highlight something very important, an EP study, while we're looking at electrical impulses, is a highly anatomic-based procedure. And we know that atrial tachycardias, as Dr. Zeitler has indicated, often come from very specific locations in the atrial anatomy. And one of those places is what we affectionately call the ring of fire, which includes the crista terminalis, structures in the septum, as well as ramifying structures at the top of the septum, including the fibers that enter the bundle of Bachmann. Dr. Mayton has covered that an EP study can be a very valuable diagnostic study in persons with pre-excitation, again, for 3 reasons. It lets us make a diagnosis. It helps us understand whether that patient is at risk for potentially life-threatening heart rhythm disorders. And then finally, it provides the opportunity to potentially cure the patient of their arrhythmia syndrome and their arrhythmias. With invasive testing, we can ascertain a number of risk factors that aren't always discernible from an exercise test or non-invasive monitoring. We can determine the shortest conducting period over the accessory pathway. We can determine the refractory periods of the accessory pathway, and we can make inferences and diagnoses based upon what happens if the patient goes into atrial fibrillation, which can often be a dangerous situation for someone who has an anterograde conducting accessory pathway. So again, the details are not important. It's important to understand that that an EP study can be very helpful in this situation, as can non-invasive methods, as Dr. Mayton has indicated. Shown here is an example of us mapping where an accessory pathway is connecting the atrium ventricles by pacing from the bottom chamber. Now, it's important to recognize that this is a lateral accessory pathway, so mapping it with V pacing is helpful in this situation. It's not necessarily helpful with other accessory pathways. This is an important slide. It talks about the complication rates for EP studies and catheter ablation of supraventricular tachycardia. And what you'll see here is the serious adverse complications like requirement for a pacemaker or death are very, very low, but they're not zero. It is important to recognize that some supraventricular arrhythmias, like junctional tachycardia and some septal accessory pathways, tend to have higher rates of complications, mostly because of the vicinity of these arrhythmias to the specialized conduction tissue. I should also mention that in clinic, a careful discussion of these risks and engagement in shared decision-making is important. Before I end, I do want to cover another invasive form of diagnostics that can be helpful for supraventricular tachycardia, and that's the insertable cardiac monitor. Although I would argue that for supraventricular tachycardia, this is a technology that is relatively infrequently needed. These are monitors that sit in the underneath the skin in the chest and can record electrocardiographically continuously, capture the presence of an arrhythmia, and then allow clinicians to review it and make a diagnosis. In conjunction with the prior presentation, there is a spectrum of monitoring, and the implantable loop recorder or implantable cardiac monitor that I showed you on the prior slide is at one end of that spectrum. It can provide continuous recording 24 hours a day with a battery life in excess of 3 years. Of course, it does have to be inserted in the clinic or procedure room and carries a little bit more risk and expense than these other methods. However, clinical trials have shown that in certain instances, these monitors can be helpful, and I just chose this as one example. This is a study of pregnant women where there was a diagnostic dilemma as to what arrhythmia they were experiencing or if they were experiencing an arrhythmia. And the bottom line of this study is that the diagnostic yield of the insertable cardiac monitor was much higher than a traditional monitoring approach with non-invasive techniques. So just to summarize the key points, supraventricular tachycardia is typically diagnosed with non-invasive electrocardiographic monitoring. However, frequently, the next step that is optimal for the patient may very well be an EP study, where specific identification of the arrhythmia and mechanism can be completed and then enable therapeutic treatment with ablation that is often curative. EP study and possible ablation of symptomatic SVT is typically a Class 1 indicated therapy, and implanted cardiac monitors can be a useful tool in cases of difficult to detect arrhythmia. And I thank you for your time and attention.
Well, Dr. Piccini, thank you for an excellent presentation. This is a fantastic session. Everyone did just wonderful presentations and gave us a lot of insight into supraventricular tachycardias. And I wonder if we can get the entire panel up so we can have some discussion. And we have some questions, but I want to start off with a question that will encompass all of these questions in some way and form that I think are important. And I'd like to really ask all on the panel to respond. The first question, though, I have is for Dr. Zeitler. And it's really, this is a multi-pronged question. And I want to give you an example of a case, just because it's a patient I happened to see in clinic a couple of days ago. And it was a 71-year-old woman who has a history of coronary disease, who came to my clinic with a heart rate. She came in for an echo and her heart rate was 150. And she came to my clinic after that and was going at 150 with a blood pressure of 166 over 110. And she said she'd been in this rhythm for about 2 weeks. And I understand all about the different mechanisms that you were discussing, but I mean, how important is that in terms of how I managed that patient at that time? And what would you do in terms of your evaluation? And I can give you a little bit of insights about what was found. But I mean, how does this mechanism make a difference in terms of the acute management of that patient with SVT? Does it make a difference? I mean, certainly in the long term, as Dr. Piccini has said, there are going to be patients that have flutter, there are going to be patients that have accessory pathways, there are going to be patients that have AV node reentry. And for each one of these patients, ablation is certainly a possibility. But in the acute management, what are you going to do here? And then I want to ask Dr. Baton a little about this and go through some of the SVT ACCHA guidelines, of which I was a writer. And I still have some questions about how good some of these things are, because one of the questions comes up about the vagal and adenosine responses. But anyway, Dr. Zeitler, what are your thoughts?
Well, that's a great question, because I think all of us who practice outpatient medicine are likely to encounter a scenario like this, like you've described on one occasion or another. First and foremost, it may seem obvious, but it's so important that it's worth repeating that the most important thing is to make sure the patient is hemodynamically stable. You described a patient who is indeed stable with a blood pressure that is well north of what's necessary to perfuse the brain.
I should say she has chest pain too.
Okay. Well, so, it sounds like she, normally when we talk with patients about SVT, one of my commonly repeated phrases that it's not acutely dangerous, except in the case when a patient may have coronary disease, like your patient, then you can certainly have demand ischemia in the setting of persistently, rapidly conducted rhythm of any kind. And so in a patient like that, the goal should be to, it's nice if you can do things to try and make a diagnosis, but the most important thing is to abort the rhythm so the patient can have relief from their symptoms and avoid any potential long-term consequences or short-term dangerous consequences from myocardial ischemia. So in the absence of ability to terminate the rhythm, at the bedside with some of the maneuvers that Dr. Maton talked about, then that patient may need to be referred to the emergency room for more advanced intervention, IV administration of IV medications or cardioversion. And long-term, I know we're talking about the short-term interventions to intervene on a patient who may be developing ischemia from the rapid SVT, but long-term, we would want to be sure that we're avoiding problems with tachycardia-induced cardiomyopathy, which is a real risk in the setting of incessant SVT. So I'll stop there. I'm sure my colleagues have other comments about this case.
Let me just give you a little bit more information, and then maybe Dr. Maton can chime in, because she came to clinic and we did an EKG, but and so that was one of the things I want to talk about. But we also got some history on her, and I think that again, history is going to be important because she's had history of this for years, but sometimes the episodes last for weeks or months at a time. And the echo was done while she was tachycardic. Actually, her EF was normal. She had a little MR, but otherwise nothing. EKG, I think, again, in terms of mechanisms, she had a P wave that was between each QRS complex, and she'd had some PVCs, but the PVCs that were there, the P waves did not relate to the PVCs. The P waves were constant throughout. And looking back at the old EKG that was a sinus rhythm EKG, there were similarities in the P waves, but they were not identical. So anyway, Dr. Maton, what are your thoughts about this, and how I will tell you what I did, but before I do, maybe you can tell me, how you would approach. Again, she just walked into clinic, and she's hypertensive, chest pain, tachycardic, EKG, P waves are similar to that in the sinus, but not identical. She'd been on, actually, someone started on a big dose of beta blockers ultimately, and it didn't do a thing. But anyway, what would you do with her?
So I think Dr. Zeitler highlighted the important sort of initial interventions that we need to take, as well as considerations that we should be thinking about. So we mentioned hemodynamic stability, but by the same token, in a patient with active chest pain, time is of the essence to try and terminate her arrhythmia. So I think that absent having the ability to, administer medications in your clinic, you could consider trying vagal maneuvers, although I'm less suspicious that that's going to be effective in terminating her arrhythmia. But again, it may require referral to a location where she could receive more definitive therapy, be it intravenous agents such as adenosine, and again, we'll see if that's effective, and or maybe even cardioversion in a patient, synchronized cardioversion in a patient who has ongoing chest pain and a tachyarrhythmia. But so, did you do a vagal maneuver on her?
Oh, yeah, so I want to get back to that because yeah, I did actually, and I want to ask you about your approach to the vagal maneuver. This may sound simple, but we talk about carotid massage and as though it's real easy, but a lot of people don't push correctly. And there are various ways of doing it. You can do it supine, you can do it sitting, you can do it various ways. And I was wondering about your thoughts about which vagal maneuver. I mean, I did carotid massage on the right and on the left, and I did it with 3 fingers, and I did it pretty hard, and I did also supine. Didn't do anything, but I mean, did I do the right thing? Should I have done some other Valsalva? Is there some other thing that you'd recommend?
It's a good question. So I think this is one of those instances where you should do what you're most comfortable with. And so I tend to start with carotid sinus massage as well. As you described, I push fairly hard. I use at least 2, probably 3 fingers, both sides. And I do it while I supine in case I cause someone to have syncope when I do the intervention. But the data would actually suggest that sort of a modified Valsalva maneuver where you have someone bear down, which people often have a difficult time doing. So sometimes people say breathe into actually blow into a syringe to replicate that bearing down sensation, followed by putting the patient supine, elevating the legs, has the highest likelihood of terminating an arrhythmia. That's what the data would support. Sometimes it's a little difficult to do in a clinic situation.
Yeah, and I listen for bruits or no bruits, and I've had some patients that have told me different things. Actually, on that same day, someone told me that only when they cough it gets better, and others have told me that they actually stand on their. One told me she stands on her head to get the episodes to stop. I don't know, Dr. Piccini, Dr. Russo, any other thoughts about vagal maneuvers or anything else you do before trying a medication when you have to put an IV in, give adenosine, and we'll get to that in a second. But I mean, any other thoughts about what else you do?
Well, the only thing I would chime in is that all of our clinics are different. And so getting things done in clinic is often very different from one clinic to the next. But in our clinic, patients get an EKG typically because they're typically coming to see us for arrhythmia. And we educate our ECG technicians that if they see an arrhythmia on the EKG, or if the patient's there for PVCs or PACs, we ask them to run extended paper. And we tell them if they see anything concerning to come find us, because what's really nice is if the patient's already been set up for the 12-lead ECG and they're in an arrhythmia, that allows you to do these maneuvers with running paper, which can really be helpful in sussing out some of the things on the differential diagnosis. And then the last thing I'd say is our webinar today has kind of honed us into a narrow differential diagnosis, but we should keep in mind that obviously things like sinus tachycardia, PGRT, atrial flutter, all of those things are on the differential diagnosis, and many dynamic maneuvers, if we have the tracing captured in real time, can be helpful in those situations.
Mm-hmm. And just to minor things to add, I think they've pretty well covered the question. But sometimes I'll do both. Sometimes just having them not just sit down but lie down, relax a while, do the same thing, hook up an EKG, and then sometimes have them do both. The Valsalva, take a deep breath, bear down like having a bowel movement at the same time that trying to to rub on a carotid. I have not stuck someone's face in ice water or anything like that. So it seems pretty uncomfortable. But I think, one of those things, fortunately, usually if it's slow enough. Now, if it's really fast and it's 230 beats a minute, probably you're not going to get into the timing, to block in the AV node there.
Very good. Actually, one of the attendees asked a question about and Dr. Maton, in one of your slides that you showed vagal maneuvers, adenosine, and that was from the guidelines. And looking at that, I don't know if you can put that up real quick, but if not, we can just talk about it. because on that guideline, it was about stability and instability. And if things were stable and, no response to adenosine, ultimately, I think cardioversion was a consideration. Now, the one concern we have, and Dr. Piccini brought this up, is what if this is sinus tachycardia? Because a P wave looked a lot like sinus rhythm, and it could be sinus tachycardia. She was hypertensive. Maybe she's got a pheo, or who knows what she's got that's making her tachycardic. She could have inappropriate sinus tachycardia. And so you certainly don't want to do a cardioversion of sinus tachycardia. So you need to know something about the mechanisms, presumably, and you'd like to have a response. So maybe for the panel, sometimes you don't get a response to adenosine. This is another one of the questions that was asked by another attendee. How much adenosine can you give, and when would you not give adenosine, and when would you maybe not expect to see a response to adenosine? I can give a couple of examples, because I know one contraindication of adenosine is heart transplant, because you could get asystole. But any other thoughts about when adenosine may not give you the kind of response you want, and how much you might give?
So I think that, the guidelines suggest starting with 6 milligrams and increasing to 12 milligrams and repeating for a second dose of 12 milligrams. I think that sometimes when you don't get the response that you would like to see, I guess it's important to know if the patient actually has symptoms in response to the administration. So if the patient's not telling you that they don't feel poorly following the administration of adenosine, I wonder if you actually delivered the adenosine effectively. So that to me is my sort of checkpoint to make sure that we've got it in an IV that's actually getting to the patient following with a big bolus. And I think that in certain instances we've can consider giving more adenosine, but I think probably if 12 milligrams isn't effective, it's probably unlikely that we'll see significant benefit with more adenosine than that.
I mean, so some of the imaging stress tests, you use adenosine,
Right.
and again, there are times that there are certain recommendations and things that can get in the way. For example, we don't use this very often, but theophylline can block the effect of adenosine, and so phosphodiesterase inhibitors or caffeine, big doses, may be, something that, so you could give adenosine and give 6, you could give 12, you may not get, but you want to give it as a bolus. You want to make sure you give, some kind of a chaser. And some people do get lots of side effects to adenosine. So sometimes you don't want to use it if they've had previous experience.
And only to add to is where you're delivering it, right? So if you're delivering it, you talked about the transplant, you're very low doses, if you either don't use it or low doses work. But if you're delivering it up a long line, it's going to take, the half-life is so short, by the time it gets to the patient, it's less effective. You're giving it through a central line, you may need a lower dose to consider that.
Yeah, so
Oh, I was going to add, that one of the attendees, part of the question was, I think, related to, the cadence of delivering escalating doses of adenosine. And I think Dr. Maiten's point is excellent about, ask the patient, how did you feel? And if they don't have symptoms from the adenosine, or even if they do, it's important, I think, to check a blood pressure between administrations. And that may sound simple, but I think it's important because even if you don't see a change in the rhythm, you may see a significant impact on the blood pressure. And then the adenosine there is effect from the adenosine, maybe not what you're hoping for or looking for, but it's important not to stack the doses of adenosine in rapid succession if you're getting some hypotension.
And then I guess finally, just to round it out, of course, there are other situations where we want to avoid adenosine in addition to cardiac transplantation. So anytime we see fast, broad, and irregular, that raises the specter of pre-excited atrial fibrillation, which we want to avoid giving adenosine and blocking the AV node and facilitating fast conduction down the accessory pathway. That's another one. And then another one we often don't think about is our patients who have profound forms of reactive airway disease. And those patients, administration of adenosine can precipitate respiratory distress. Just things to think about to round out the rest of the list.
Absolutely. In this case, I was hoping to give adenosine. The situation was a little complex, but because I wanted to see if it would have stopped. It looked like either SVT, an atrial tachycardia, or a sinus tachycardia. And as Dr. Zeitler has mentioned, a lot of times you have this automatic type atrial tachycardia, which doesn't stop with adenosine, but there are adenosine sensitive atrial tachs. I just want to see if it would have stopped. but it didn't happen. That didn't happen. What ultimately happened was I got a little bit more history, and I know their time is we're just about finished here. So just to give you what happened with her, got some history on her, and I looked back at her long-term monitoring, and she had this abrupt onset of tachycardia, and it stopped, and would go on for minutes at a time. So it looked like an SVT. It didn't look like sinus tach, where gradually going up and going down. And I got a history. She had been to an emergency room before, and they actually gave her IV cardizem, and it stopped. And so we actually give, so one thing to keep in mind is if adenosine doesn't work, sometimes calcium channel blockers, IV, can stop some of these tachycardias. I'm just wondering if there are any final comments before we have to close this session about the use of calcium channel blockers for SVTs. Because
Other than never use verapamil if the patient has wide complex tachycardia, that'd be
Right.
the only other pearl to throw on the
absolutely.
vignette.
That's great. This has been just an amazing discussion and amazing talks. I really, truly want to thank everyone, thank the panelists, thank my co-moderator, Dr. Olshansky, and most of all, thank the attendees. I think we could go on we always feel like we don't have enough discussion time, but really thank you for attending this. And as a reminder, this is just, as listed here, just the first of a 3-part series in our initiative for SVT. So look out for the others to come. The next one will really focus more on, the treatment of SVT, which, and Brian and I were both on that document years ago, which I think is still relevant, for how to treat it here. And we'll get into more, case scenarios with the very last webinar. So, today's webinar was recorded and it'll be available soon through the learn.heart.org website. So thank you again, and just have a wonderful day.
Thank you.
All right.
Thank you. Thank you.